thanks for joining, first of all. I'm sharing the session this evening with Catherine Forch. I'll probably call her Cat. So that's who we're talking about. So for those of you who haven't met Catherine, most people call her Cat, I think.
Yeah.
So the plan today is we want to talk about some of the things that are new at our clinic around the topic of concussion. My plan is to talk a little bit about the initial diagnosis of concussion and some of the challenges there, and hopefully give you some tips that you might be able to use to help improve your initial diagnosis and management of concussion. But also just to talk a little bit about models of care. First, more generally, like what does the community management look like? But then to talk specifically about some of the models of care that we have within our clinic. The first thing I wanted to say is that concussion, this definition of concussion comes from the consensus statement in sport. I imagine many of you will have looked at this, but it also as a definition I think works quite well in concussions that occur outside of sport too. And the main thing I want to emphasize here is that you can get a range of different signs and symptoms. And so one of the things that's difficult about concussion is it can be a subtle diagnosis. But the two things that I think are really important to kind of reflect on is that these symptoms need to be associated with some form of trauma. And for most people, this is a problem that resolves fairly spontaneously over a period of time. And so I think what we see in our concussion service is that there are some patients who have a range of clinical signs and symptoms, often with some relatively trivial trauma, and often without any improvement over time, and often sometimes a deterioration over time. And so one of the things we want to talk about today is that concussion? Why might people continue to have symptoms after a relatively trivial accident when other people don't? And some of the different ways that we might be able to go about managing these symptoms, because they're certainly real. As I think you'd be well aware, there's not a good diagnostic tool for concussion. So you might read about various technologies, read about biomarkers. The media is very good at coming up with the new or novel solution that's going to help us diagnose sideline concussion or help in community EDs. But unfortunately, we don't have that. And so most of the time we're relying on tools like this one. So the SCAT6 is very commonly used in sport. We use the BIST, or the brain injury screening tool, which we'll talk about a little bit more. But it's really important to understand that these are tools that are there to help clinicians try to identify or raise suspicion of a concussion diagnosis. They are not a reliable diagnostic tool. And so this is a case from last week in one of the Warriors players I look after, where someone came to me after the game, several days after the game actually, and reported experiencing trauma in the game and experiencing some ongoing symptoms. And so in the NRL, we use something that's very similar to the SCAT. And you'll see that this patient reported some symptoms. So at their baseline, they had a symptom score of 1 and a symptom severity score of 1. So that's at the far left at the top. But then post-injury, they had a symptom score of 8 and a symptom severity score of 13. So in the context of trauma in a fairly high-risk patient like that playing a high-risk sport, there's a reasonably good chance that that person's had a concussion. But then if you look further down, you can see that their scores are at their baseline for all of the measures in the standardized assessment of concussion, the SAC. And in the same week, we had a patient who had a very high symptom score, a normal SAC, and that we did not think had a concussion. So it's about saying, does this sound like a concussion, and what evidence can I find? And in this particular case, because of his profession, you want to have a fairly high index of suspicion and err on the side of diagnosing a problem. So that's certainly true at the community level. In rugby league, we are lucky in that we have an independent medical assessment. So someone is watching the video feed of the game as we go, and they're able to tell us whether they've seen something that looks concerning. So for those of you that are interested in the NRL, there's category 1 signs and symptoms, which I've listed here. That mandates that the player is removed from the field of play and can't go back on. Category 2 signs and symptoms are very similar to this list, except there's a word suspected. So suspected posturing, suspected confusion, those sorts of things. And so those are the ones that go into the change rooms for a head injury assessment. So looking at that list, it feels quite black and white. So if someone is having a seizure, someone is posturing, there's really not too much gray there. It's fairly obvious that that person has a pretty significant problem. I'd like to draw your attention to H, which is motor and coordination. And that basically is when someone's hit and staggers around and looks unusual. So I'll show you a couple of examples of that. This will roll forward for about maybe 20 or 30 seconds, but this player may be posturing, certainly is having a hard time getting up, and certainly um, is not in control of his arms and legs at this moment in time. Next one is one of these yellow players, the Parramatta Eels, gets up, staggers around, clearly impaired, clearly not normal. And again, in the context of trauma, that is almost always a concussion. These things do not appear like subtle things. The difficult thing is that often these players come from the field of play. They will walk off. They will not remember anything about that period of motor and coordination. They will be quite indignant that they've been removed because they quite quickly feel back to their normal self. And then when you do their standardized assessment in the dressing room, their HIA, they will pass that and have baseline scores, no symptoms, normal balance and coordination, normal memory scores. It's a very interesting cohort. So that's a problem because if in a community sport context you don't see the mechanism of injury, this white player, the St George Dragons player, he looked like he recovered pretty quickly. And I imagine by the time he's talking to the trainer here, that he would be quite lucid. The other thing is that if you see this and you send them to the ED, it's very likely that that player or their parents or someone else will say that they're fine, that they haven't had a concussion. And so you need to send them with some very clear information. So these things are very obvious, but you might miss them, number one. And then number two, this diagnosis might be missed because they're not sent with all the information to the emergency department. So it's pretty consistent data. This is from the NHL, which shows that 50% of sport-related concussions are obvious to the world. So that means sitting in your armchair at home, you will likely be able to make a diagnosis. But that also means that 50% are not well demonstrated. So I think from a community sport level, we need to work really hard with all stakeholders in sport to make sure that the right things are done for that 50%. But where our responsibility lies, the things that we can add value with, is around the 50% that are more subtle. So having a standard way of assessing those, I think, is really, really important. Another observation is that are all concussions the same? And so we talked about that motor and coordination concussion potentially being one that appears to recover quite quickly. So from a clinical perspective, that is. But you often hear about these concussion protocols, players following concussion protocols, these sorts of things. And what does that generally mean? That generally means that they're going to rest for a period of time, then they're going to progressively increase their activity and then return to their normal routine. And so this slide comes from football. It talks about a 21-day return. So I'm hoping that all of you have seen that ACC now recommends a 21-day return across all community sport. So it's a material change. And the idea there is to try and prevent the risk of re-injury or subsequent injury by having a sensible and measured return to play. The problem is it's hard to know when people have actually recovered. And so Kat is going to talk about some of the research that we've done in our clinic. And our definition of clinical recovery, which is pretty consistent with most of the literature, is that you need to have no symptoms or your normal level of symptoms. So that's probably a good point to make, that it's normal to have a few symptoms. It's the patient's normal clinical exam. So in our rugby league cohort, there are a number of players who've got a stiff neck because they've had a cervical fusion. And so it's normal for them to have a stiff neck and a slightly uncomfortable neck. And then they need to have completed that graded return to play. And so that is the definition that is widely used in the literature. That's what we use. But unfortunately, if you look hard, about 30% of players who have clinical recovery will still have some residual cognitive impairment. And so that's from a range of different sporting contexts, but it's fair to assume that that'd be the same across all contexts. And Kat, I think, will show us some evidence soon, which shows that some of the physical deficits also persist. And it's really difficult because I don't want my players going back and I don't want my other patients going back to high risk activities until that cognitive impairment has improved. And so one of the things that we've added into our concussion protocol at the clinic and also in the NRL and Super Rugby is something called a cognogram, which is a computer-based neuropsychological assessment. So that test is best done pre-injury. So in professional sport, it's done in the pre-season. And then if someone gets injured, we repeat these tests and we can compare them to them. So has their level of cognitive function returned to their baseline level of cognitive function? You can also use this test by comparing to the normal population. And so in our concussion clinic, all of our patients that go back to high risk activities have a cognogram at the end to try and show that at the end of their care, to try and show that they are within a normal range. But then that then becomes their baseline measure that we can use should they have another concussion. There's another cohort where we've started offering this as a baseline tool to individuals who are interested in trying to have more information about their cognition, that want to try and minimize the impact of any future concussions. And we've really seen some benefit with it is with schools and sporting organizations where they use it as a baseline tool for their players. The other thing about the return to play process or the concussion protocols is you have to ask yourself whether they are the same for every player. So this is well played out in the media. So Wade Egan is one of our NRL players. He's had a number of concussions. And so my question is, are the NRL protocols applicable to him for his 5th or 6th concussion? Are they applicable to someone after their first concussion? So it feels to me that they are very generic and that some nuance needs to be put in place when you're trying to make some decisions about return to play when someone's had a number of concussions, and the 10-day or 21-day protocol is probably not the way to go for them. Similarly, it's very hard to criticize. So if I was to tell you that insert player A had multiple concussions, but had an absolutely normal neuropsych assessment and actually was in the top 95th percentile for most measurements, that might also make you feel different about return to play. So I think with these people that have had multiple concussions, it's really important to understand that there's a lot of nuance, and trying to collect as much data to help make a good decision as you can is super important. Just very quickly, I want to talk about the injury to Ali Katoa. So I don't know whether you guys have followed this, but it's been very well litigated in the media. But Ali Katoa had a subdural hematoma. That is not a concussion. So it's a brain injury, obviously, but it's a completely different problem. And I found it quite frustrating in the media having the two kind of compared, or the line being blurred between the two. The other thing that you've probably read about is that the clinicians involved with managing this problem have been heavily sanctioned by the NRL, which, in my opinion, is not appropriate. These people made good decisions and were judged on an outcome rather than the injury and the situation. But I think it's important to kind of think about that from a personal level. When you're working at sport, are you equipped to manage trauma? Are you working within the scope of your practice? Because if you're not, you may not be judged well by either your peers or by regulators. So for those of us working in a professional sports setting, those of us putting ourselves on the sideline, it's incumbent upon us to be prepared to manage the full spectrum of things that may happen there. Kind of moving on a little bit to models of care. So I've put this here because the quote on the left, concussion recovers within 7 to 10 days in 80 to 90% of cases. I'm sure you've read this. This is in lots of literature. It's in pretty much every edition of the consensus statement in sport and concussion. And if you look closely, that all comes back to some expert opinion from the 1980s. There's very little data to support that. On the right-hand side is data from our clinic that says only about 50% of patients have recovered at 2 weeks post-injury. So it takes about 6 to 8 weeks to actually get back to the 80 to 90% mark. And that's only when they have a standard model of care. So in this study, all of these patients were seen by a doctor, a physiotherapist, and an exercise physiologist within the week of their injury and had regular follow-up. So I would say that the 50% at 2 weeks is the best possible situation for sport concussion in New Zealand. So highly selected group that are probably very motivated to get better. And it may be difficult to apply those stats to people that get injured outside of sport, who sometimes are potentially less healthy, less motivated to get better. And so I think the key take home here is it takes longer for people to recover than we thought they did before. Excuse me. Most people who get concussed in New Zealand, the recommendation is to go see your GP or go to urgent care. But as you know, it often is pretty challenging to get in to see your GP. And so that can be a problem. We know that when symptoms are, well, the problem is relatively uncomplicated, primary care works really well, and your GP assessment plus a physiotherapy assessment works even better than general practice on its own. And there is no doubt there's an increasing role for physiotherapists and other allied health clinicians in the management of concussion, and we should be looking for ways to work in teams. Unfortunately, primary care funding models are based around pretty short consultations, ad hoc access to interdisciplinary or multidisciplinary care, and relatively poor funding models. And so it can be very difficult to manage this problem effectively, especially when it's not going very well in a GP context. Whereas these complex concussions often require multiple appointments over time. It's really important to think about things like vocational rehabilitation and getting back to school and work, because we know that if you can get that done early, it significantly improves longer term outcomes. And so referring into a concussion service or into secondary care is often a sort of fairly pragmatic solution to funding models, to capacity. It's not because all of these concussions cannot be managed in primary care, it's just it can be very difficult. So at our clinic, we essentially have two concussion models. So this one shows our acute concussion model. So if you are concussed or have a suspected concussion and you see a physiotherapist or another allied health clinician, we have an acute service where we will try to see the patient within the week of their injury. We offer some online assessments or in-person assessments. And effectively, we're trying to make a determination about, is this person getting better? Do they look like they're going to recover in a primary care setting with their physiotherapist or someone else guiding them? And in that situation, we would then follow them up and do a discharge, return to play type assessment. Versus some of them, it's very clear that things are not going well. They have a very high symptom load. They're not back at school or work. And so the intention there is to then refer them into our concussion service for an interdisciplinary assessment. And the goal there is to try and get the patient to see the right person at the right time. So if they have a very bad headache, it may be that is a structured physiotherapy assessment plus a visit with a doctor to talk about physiotherapy strategies and pharmacological strategies to manage that patient's headache. If they have a high level of anxiety, it might be facilitating an assessment with a psychologist. If they've had 10 concussions before, it might be involving a neuropsychologist. So it's about trying to get the patient as quickly as we can to see the right person at the right time. So then it sort of flows on to like, why would you send people to a specialist service? We've kind of talked about the value of a team approach. And so our team has a bunch of doctors, concussion physiotherapists, occupational therapists, and neuropsychologists, as well as some psychologists. So we try to have our team like this. So we work in co-located groups. And unfortunately, I think a lot of interdisciplinary teams or a lot of ACC funding models have a team approach that's a little bit like this. So there might be this little guy down to the bottom left of your screen might be the key worker, the primary person that sees the patient, but they're trying to navigate a world in which the other people, the other members of their team are geographically scattered. The funding models don't really allow them to be seen. It can be very challenging. So I think the main thing that I offer my patients is that I have time. So if you think about the GP model, GP appointments might be about 10 minutes. My new patient appointments are between 45 and 60 minutes for concussion. And that allows me then to do a detailed clinical exam. It allows me to identify and treat symptoms. It allows me to spend time with our interdisciplinary team and talk to our referrers. And then all of those things lead to me doing the same thing over and over again, which means I can get good at doing these things. So I really feel that it's very easy for me to manage concussion rather than people, say, working in primary care. The next thing is that we have this group of key workers. So they are unique to that patient, or that patient's, the word unique is so overused. They're not really unique to that patient, but each patient has their own key worker. And we have a combination of OT key workers and physiotherapy key workers. So where there's a range of complex sort of social issues, often it's an OT. Whereas if it's a more straightforward musculoskeletal cervicogenic driven headache type situation, it might be a physiotherapist that is the key worker. And a key thing I think to stress is that we're not looking to take over that patient's care. So as a physiotherapist, if you refer us a patient, our job is to work collaboratively with you. If you want to abdicate the responsibility to treat these patients to us, we're happy to do that. But equally, we're happy to send back a treatment plan and let you know what we've done and what we've found as we've done an objective assessment. The other thing that we're trying really hard to do is to make sure that patients understand it's important to do things, even if it provokes their symptoms a little. I saw someone who was a professional athlete who had followed the return to play protocol in their sport to the letter. And unfortunately, the protocol said if they were symptomatic, they had to stay at that level, and they hadn't progressed over a number of weeks. And when I saw them, I asked them whether they had been exercising and doing things, and the answer was that they hadn't. And I said, look, it's absolutely safe to start to be more active. We just can't be doing that and making your symptoms terrible. So that whole boom and bust mentality is bad, but starting to do something, even if it provokes your symptoms a little bit, is unquestionably good. I think Catherine said something the other day about parallels with back pain. Going home and lying in bed, we would be appalled if someone did that. Why should we do that? Or why would concussion be any different? So encouraging physical activity, getting out and using your body and using your brain, I think is incredibly important. And then the other useful tool we have is a neuropsychology or psychology assessment. So being able to identify cognitive impairment or show that the brain is functioning very normally is incredibly powerful. When we do our IDT meetings, we'll often see these sorts of things. So the BIST score, if someone's an outpatient, is out of a total of 160. The referral criteria in the BIST say if it's above about 60, you should refer them to the concussion service. If it's about 40, you're starting to think about there is a risk of delayed recovery. We're routinely seeing people who are 90, 100, 110. And you have to say, well, why are some people's experience with the same type of injury so hard? And all of these things here can lead to an increased symptom burden. Some examples are a young woman who's had a fairly trivial incident here when she's hit her head on a car boot. And looking for a flat kind of just sort of intimates that some of these people have a really high, there's lots of things happening in their life that lead to them having a BIS score of 82. It's not just banging your head on a car boot. Similarly, we have this type of patient who enjoy playing sport. This guy's had a number of concussions, has a BIST score of 0, which is not unheard of, but it does raise a little bit of a yellow flag to me and is desperate to get a clearance back to playing sport. So these people have potentially got different issues at different ends of the spectrum. And this is another common one where a very important person comes in and they're just not prepared to change their lifestyle or change their work life, which means that they find it really hard to get past their symptoms. They feel grumpy and then often end up kind of breaking down with lots and lots of symptoms. So we've got lots of different types of patients come in, but I think the patients that are not getting better, or the patients we find most challenging, or share some characteristics, and a lot of that is around a lack of insight into their problem, whatever that may be, and trying to define what the problem is and have a clear plan to resolve that, I think, is critically important. So final slide from me is there are a bunch of patients I think it's totally fine to sit and wait and see whether the patient gets better. But there are definitely also a cohort of patients that are best referred early. So people with lots of concussions, they'll often become, relatively or report being asymptomatic quite quickly. Being able to understand what their brain is like and how it's functioning, I think, is super important. And then patients that are off work and school, I think increasingly we realize that doing something for those patients early is really, really important in trying to get their routine back underway. So I'm going to pause and pass on to Kat.
Yeah, my name's Catherine, or in my physio life, I do get called Kat a lot, much to my mother's horror. She named me Catherine. I'll take any version of it, just not Kathy, because then I feel like I need a minivan. So I'm a physiotherapy specialist, and my area of specialization is concussion. Full-blown concussion nerd. Love talking about all of this stuff, and I'm quite proud to share some of the, I guess, things that have informed the development of some of our pathways and things in terms of how we practice, and a little bit of reflection looking back to how things used to work. So back in the day when we first started our concussion service at Axis, we had some palliative funding from ACC, and there was a team of 3 of us, as Fulch touched on. So we had Stephen, myself, and Hannah, who is an exercise physiologist, rattling around in the back of some sort of cricket club rooms at our old clinic site. And it's quite cool to sort of see where it's gone now. So we have 9 clinics across the Motu, and we see over 1,000 concussions annually. We have a little cluster of clinics in Auckland, but we're getting more of a presence in the south, and it was really cool to spend some time with some of the clinicians working down in the South Island when Fulch and I were on the road with Julia last week. And we have all sorts of very clever, whizzy people under our umbrella, which, as Fulch mentioned, makes things a lot easier in terms of that collaborative approach and having different perspectives and ideas that you can bounce cases off, because any of you working with people after concussion, it's a difficult time for them. And so sometimes just having that support network and other people to sort of bounce ideas off is really, really helpful. The other thing I think is really cool around our clinic processes is that we're very, very focused on research. There's a lot we don't know about these injuries, but we're trying to answer some of the questions that crop up for us clinically. So we have current research collaborations with a whole lot of very clever people at a whole lot of organizations. And I just wanted to touch on some of our outputs to date in terms of how they have changed both our practice within the clinic, but also kind of our understanding of these injuries in Aotearoa context. So Fulch shared a little bit of the recovery timeframes, and this comes to some of the commentary in the chat around the fact that there was this preconception that most concussions sort of recover within 7 to 10 days, and that was cited quite widely. You see it cropping up in the media, and often GPs will be giving this expectation. But this was a cohort of patients who our criteria to see them under that funding model at the time was that we had to see them within 10 to 14 days of the injury. So they had very, very early access to care. And it was a quite young cohort, mostly male, and they were all sports related concussions. So if we look at those prognostic factors, for people to recover well, the deck was stacked in their favour. But actually we found that it was more like around the 4-week mark where most people were better by. And then we had this bit of a tail that went right out to sort of the 8-week mark. 95% of people were better within 8 weeks. But as you say, if you add on some of those other modifiers, it's very clear that concussion recovery, we should be thinking about it in terms of weeks, not days, for the majority of cases. And in a lot of cases, months can be quite normal. The other thing we found in that piece of research is that when you start to target their intervention early in terms of specific management in relation to the subtype of concussion that they have, that people recover faster. And the analogy I sometimes use is it's a bit like treating a knee like an elbow. If you treat a knee like a knee, it will generally recover a bit quicker. So at the time when this research came out, a lot of the current practice of how we managed concussion in New Zealand was a very kind of rest and pacing and planning and fatigue management was the main approach. And so we showed that kind of getting active early is really, really helpful. This was also some work out of some of our patient group where they identified some of those prognostic indicators. So it's always difficult when someone's in front of you, how long's a piece of string, how long are we going to take to recover? And so having an understanding that being female, having involvement with your sensory motor systems or experiencing dizziness and having a high symptom burden all show us that we need to reset our expectations that maybe this might take a little bit longer for this person to recover from this particular injury. Armitesh also built on that. Armitesh is one of our fellows, and he looked at the prognostic value of the concussion treadmill test findings. And so there were some things that came out of that. Obviously, very early time to failure on the Buffalo test was prognostic, but also there were some things around it was good if you were seen earlier, if you were male, if you were younger. And also if you had a cervical, so neck dominant presentation or a physiological dominant presentation. So I saw a patient with concussion today who had a very typical kind of physiological picture. So a little bit of headache when they bent over, so kind of pulsing, pounding headache, a little bit of exercise intolerance, a little bit of sleep disturbance. And so in my experience, those type of patients tend to recover quickly, bounce back quicker than someone who's presenting with kind of complex dizziness and things like this. This slide kind of blows my mind a little bit because when we first started managing concussion, as I say, it was just me in terms of the physio side of things. And now we've got this whole crew of very clever people who are involved in one way or another, depending on their appetite for concussion. So we have some of our less experienced or more junior physios who might work with our very straightforward kind of acute patients, and then we have some who are full-blown concussion nerds like me who enjoy really unpacking those complex cases, and then some in between. And I think when we're thinking about intervention in respect to, this is how I would look at things in terms of physiotherapy management, it's having these conversations with your patient, because the reality is that it's almost never linear recovery from these type of injuries. And so I think a big part of our role is to provide them with some tools that help them navigate this sort of whirly-burly process. So it's how do they pick themselves up from the lows, and how do we sort of level things out so that in the end the recovery trajectory is heading in the direction that we want. And one of the big ways that we try and do that in terms of how we approach assessment and management of people in clinic is starting to look at the symptom drivers or the sort of phenotype that may be associated with that person's particular injury. So this is a concept that came out of the concussion in sport group. Sorry, the chat's blowing up and I need to stop looking at the notifications. I'm trying to read them at the same time while I'm talking. So it's this idea that sort of concussion is an umbrella term, and actually there's subtypes of concussion, or sometimes they're called phenotypes. And the main ones that we typically see in the literature is vestibular, so our inner ear, our balance organs in our inner ear, the visual systems, the cervical spine, your cognition, your mood, sleep disturbance, and then autonomic issues. So autonomic, talking about the kind of, I guess, background systems that just help people operate, regulating heart rate, blood pressure, those type of things. And it's really important if you have someone sitting in front of you who is having a concussion that may be presenting like this, where a lot of their symptoms are driven from, for example, vestibular dysfunction. Maybe there's a little bit of some visual stuff and some neck going on. And we were treating them with a fatigue management, pacing, planning kind of not active model. That's where we're treating a knee like an elbow. So the idea is that we're trying to identify the systems that are involved, and then we can start to target our intervention. And one thought I'd like to leave you with is this idea of phenotype specific patient reported outcome measures. So as Fulch touched on, you will see the brain injury screening tool used widely, and that's been picked up by ACC, and it's now one of the requirements to use with people under the concussion service. But it actually wasn't designed to monitor recovery, and I say that as one of the authors, I'm not bagging it. It does a really great job in terms of determining, guiding clinical decision making. So it gives you an idea of if you should escalate care, but it actually wasn't designed to track someone's progress through time. And so using these are just some examples of patient-reported outcome measures that would be aligned with these phenotypes. There's others that you could use, and you probably do, but it's quite valuable if you have someone in front of you for two reasons. One, that they often will feel validated. If you're filling out, for example, a brain injury visual symptom survey and there's a symptom around, the words swim on the page or something, there's this feeling of like, oh, this isn't just me that's experiencing this, it's quite a normal thing to do with a concussion. So that helps. The other thing is they'll often be a little bit more responsive to change. So someone who's having a tough time may be thinking they're not making a lot of progress, but if you're using an outcome measure that's a little bit more responsive, then that can be really helpful. If someone comes to see me, there's a couple of really big rocks that I want them to understand or to take away from that consult, because I feel like it sets the scene for how we're going to progress through our management plan. And all of our clinicians will talk about these type of things to varying degrees. Fulcher's already touched on the +2 kind of symptom rule. So the first thing is giving them a little bit of an understanding of actually what's happening in their brain in terms of the pathophysiology. So we know that after concussion we can have this metabolic crisis, and we have this supply and demand mismatch in regards to fueling of the brain. And that's quite important for them to understand, because it helps get them on board with one of our cornerstones of management, which is this active rehab idea. There's every single person that comes into our clinic is put on a treadmill and assessed and is given an active rehab program of some degree. And so if they understand the why, they're much more likely to engage with you asking them to go for a walk or whatever, instead of them just thinking it's kind of generic advice. Coach has talked about the +2 rule. It's really, really important that we give some people some parameters around what's too much and what's too little. And on the next point is to really respect the nervous system. So we know that in a lot of cases after concussion, they will sit a little bit fight flight. So often we see sympathetic dominance. And what we're trying to do is just encourage the system back to that kind of state of being regulated. So if you go and load somebody up with a whole lot of, for example, impairment-driven exercises, and you drive that fight-flight response, you're really doing them a disservice. So we need to understand that those responses are there as a protective mechanism, but that needs to be integrated as we sort of consider our progressions, and give them some tools in their toolbox to manage that. The messaging I give them in terms of rehabilitation, whatever it is, whether it's neck or vision or autonomic or vestibular stuff, is that the idea is kind of this graded exposure. So we're trying to introduce normal, healthy, ideally predictable, repeated input, so the brain can, for want of a better word, recalibrate. I sort of use that phrase a lot. It's kind of a simplified way of explaining what's going on, but patients often kind of get the idea of that. And I think getting people outdoors is really, really underrated in terms of a rehabilitation intervention. I think, getting them away from artificial lighting, that overstimulation side of things. So part of what we want to think about with our active management in terms of our aerobic exercise is maybe I'm not going to ask them to sit on the exercycle in the gym every time. Maybe I'm going to alternate that with some time outdoors, and it may be having a slightly different impact on what we're getting out of the intervention. So just to cover those sort of 4 physical slices of the pie chart, so the autonomic, visual, vestibular, and neck, these are some kind of big rocks of things that I would generally tend to do with almost everybody. As we mentioned, we systematically assess everybody's exercise tolerance, and I think that's really, really useful. There's a lot of research showing even just the first 4 minutes of a buffalo treadmill test can really tell you some interesting things about what's happening with the autonomic nervous system. And then I'm often giving patients some circuit breakers, I call them. So ways to help manage that fight-flight response, and often they can be quite useful kind of symptom mitigators. So if things are creeping up a little bit, they're going to do some of those strategies. And I'll pitch that depending on the person's sort of tolerance for woo-ness. There are some people that are very tapped into mindfulness, and all of those kind of things resonate with them. And for some people, that's way, way out of their comfort zone. And so I'll kind of do it relative to what I think their appetite for it is. In respect to the neck, I think of my intervention in terms of 3 buckets. So I will use manual therapy a lot with this patient group. I think showing them that their symptoms are changeable within a session is really, really powerful to sort of counteract some of the fear that people can experience with these type of injuries. And then I'll give them often some type of symptom management themselves in terms of a home exercise that they can do. Lots of mulligan type techniques I use. Snags go really well with this patient group, for example. And then depending on what they're wanting to go back to, their meaningful activities, we need to have a think about the force output and ability of the cervical spine. So what's the sort of endurance like? What's their rate of force development like? And are they going to be able to mitigate force if they are returning to kind of high risk sports, for example? And then also thinking around how is the neck currently operating as a sensory organ? So when we think about motor control, we know that the neck is telling the brain about the head's position in space as well. And so we're just checking for potential symptom drivers coming from that aspect. In respect to the vestibular system, generally there's 2 possible scenarios. Either it's too busy, so that's our BPPV. So we see that in about 6 or 7% of our concussion presentations acutely. So we need to be screening and treating for BPPV. The other scenario is a vestibular loss. So it's not working as much as we'd like it to be, either on one side or sometimes on both. And that can typically affect VOR. So we can have some impact on gaze stability. And we can have some impact on VSR, which is our balance writing reflexes. Or it could be how the brainstem's kind of processing the vestibular input. In terms of the visual system, we're thinking about how the eyes are working together to present the seeing part of the eye with a target. So how's our tracking and our pursuits? How is our ability to find and release targets in terms of saccades? And our ability to use both eyes to perceive things coming closer and away. So we're looking at vergence there. And this is what an example of what one of our physios will do in clinic. If someone presents to Axis, they will generally have this physical system screen as their first kind of in-person touch point with one of our physiotherapists. So they'll be having a look at the neck, particularly the upper cervical spine. They'll be having a look at balance in terms of a screen that might be instrumented. So I think force decks are really, really useful, and they're quite underutilized in terms of objective balance testing. We also look at the oculomotor systems and the vestibular system through Neuroflex, but if you don't have that type of technology, you could do an oculomotor exam, and we're screening for BPPV if it's indicated. And then we're having a look at their autonomic or their physiological function, and as I say, that's through a graded incremental exercise test. And then coming back to this, it's this continual reflective loop. So if we've kind of headed off in one direction and we haven't had the outcome that we've sort of expected, or things haven't progressed as we'd hoped, it's just having that ability to kind of shift gears and try something else. And that might be treating a different phenotype, that may be you know, coming at it a different way. And so I think having that ability to kind of take a step back and go, right, this isn't going as I'd expect. And it's something I'm really proud of within our team. So we do that. We will escalate internally. There's sort of this unofficial, you know, if you've been seeing somebody for 3 or 4 sessions and it's not going as you'd expect, let's get somebody else's eyes on that. And so having that really safe, kind of supportive, collaborative idea is really nice. And sometimes it's literally just somebody else saying the same things that you've been saying, and that will resonate with the patient. And then the last part is this: what does recovery look like, and what does that person need in terms of exposure to some of the demands of their daily life? Now, I'm a busy working mum with 3 kids, so the demands on me are entirely different from a professional contact sport athlete. But it's important that whoever's been overseeing my rehabilitation has had that in the back of their mind. So, you know, have I tried wrestling an angry 3-year-old into their car seat, or have I tried, you know, grappling with MMA? Like, those are kind of similar parallel things. Sometimes I feel like an MMA fighter, but it's this thing of doing a needs analysis for the person that you have sitting in front of you, and making sure that we're not rehabilitating them to kind of 80% and then being like, cool, off you go, see ya. So just to wrap up, I just wanted to highlight a couple of the, and then we'll jump into the chat for some questions. The current research that we're doing at the moment at Access Sports Medicine. So this is the first study. This is the first study of my PhD. My big picture PhD question is: can we improve return to play testing for sports related concussion? Because as Fulch touched on, I think you said I had a slide on this, but I haven't put a slide in for why. But we know there's at least twice the risk of injury when you return to sport after a concussion. So either another concussion, or the risk is actually slightly higher for a serious musculoskeletal injury, for example, like an ACL tear. So there is clearly a cohort of athletes that we are returning to sport too soon. And Fulch mentioned that they have there's evidence of lingering cognitive impairments. So we know about 30% will fail a cognitive test, but there's also some evidence of things in the sensory motor space. And that's what I was interested in looking at in terms of my PhD. I always had this gut instinct that it never made sense to me testing somebody in a clinic setting and then sending them off to go and do very high intensity, tiring things out in a sporting arena. But with my pragmatic hat on, I knew it's a real hassle to have to exert people in clinic. And so the idea with the systematic review was to look at, well, do we need to use exertion? Does that add any value to our assessment? So we had a look at studies that included an objective measure. So something you could test. It wasn't relying on the patient reporting symptoms. So it was an objective measure, and we sort of grouped them into cardiovascular measures, respiratory measures, cerebral autoregulation, which is organizing the amount of blood flow in your brain, and there's a couple of papers with visual measures. Unfortunately, there weren't any with balance that met our criteria. So at rest, you can see in a resting state, only a couple of the studies had significant differences in these objective measures between their healthy and their concussed groups. But after exertion, the picture was quite different. So we can see that after a physical exertion challenge, the number of studies that had differences between their healthy and concussed groups was a lot higher. So it does show us that exertion does kind of sharpen our assessment tools and might help us highlight some of these lingering kind of subclinical deficits that are hard to pick up that are probably responsible, at least in part, for this increased injury risk when people go back to sport. Rebecca Blythe, who's one of my fellow concussion nerds and one of our physios based out of our St John's Clinic, is doing her PhD through the University of Otago, and she's doing some very clever things, having a look at firstly the kind of knowledge and attitude and beliefs of female football players in respect to headers, but she's also done a very big deep dive into what influences head acceleration, and is now doing some a prospective study where she's collecting data looking at some head accelerometry measures and trying to answer the question of why do women experience a higher rate of concussions for a matched sport, particularly in respect to football. I think Fulch may have touched on this, but Logan, who's one of our registrars, did quite an interesting retrospective analysis of our concussion referrals to a specialty concussion service and found that only half of them actually had a concussion diagnosis. So we have this big issue in New Zealand around people presenting to a physiotherapist who cannot use a diagnosis of concussion. So a lot of these people were coming through with facial contusions and neck sprains and all of these things so that the physio could initiate care. So it's just asking that question of, does ACC really understand the scale of the number of people that are out there with these type of injuries? And then a couple of other things that we also have on in the clinic. So just as a bit of a spoiler, we've got, I'm doing a big crossover study at the moment looking at kind of return to play testing and a cluster of objective measures before and after exertion. And then Rachel Skilling, who's one of our physios based out of St John's, who sort of drives our sports pathway. She's looking at some prognostic findings from the treadmill test and some other measures. So we'll have a look for those coming out of the woodwork at some point. So just to wrap up, I think, you know, it's full circle from what we started talking about in the chat. Concussion takes longer to recover than we thought, but in most cases it should improve, and it can be quite challenging in that primary care framework. So that's where tertiary or concussion services providers can be really, really supportive, and that we want to be ensuring that that intervention is active.
So here's a question around from Carmen about what's your experience with patients' response to water, hydrotherapy, and autonomic regulation?
Interesting question. Yeah, I guess you could split that. There's the ice bath situation, which is really having a moment. There's lots of people ice bathing. I think it's in Joe Rogan podcast land. In answer to that, it's a nervous system barrage. So I've had some people who have found that ice bathing is just all a bit much at the moment, but I think you get the positive kind of dopamine release, and that side of it can be really helpful. So it's one of these things where if you try it and you feel a bit yuck afterwards, not the end of the world, you haven't hurt your brain, you've just made yourself feel a bit yuck. In terms of swimming, I don't think, to my knowledge, that anyone has looked at sort of autonomic regulation in respect to that, but I think it'll be a really, really interesting question. I know a lot of my patients enjoy swimming and use that as a rehabilitation mode for their aerobic exercise. I think one thing you just have to factor in is if they have any kind of vestibular or neck problems, often I'll get them with a snorkel. So I think it's a really, really interesting question. I don't think anybody's answered that yet.
And I think another one for you, Kat, from Jenny, that I think you kind of have answered a bit, but do you buffalo treadmill people who are dizzy and or people with BPPV?
Well, no, if they've got signs of BPPV, is not a lot of point of treadmill testing them because it's going to be haywire anyway. So we would assess and treat the BPPV first. There is a equivalent test called the Buffalo Bike test. So it's quite widely publicized. You can find the protocols for it online. The Buffalo group have put information out about that. So if I had someone who was imbalanced or a bit nervous or wasn't appropriate to go on the treadmill, then the bike is a great option for that.
There's one from Jeff that I'm going to jump on, which is around nutritional guidance for people with concussion and specifically in reference to creatine. So the idea with creatine is that when you have a concussion, your brain metabolism goes haywire, and creatine might be somewhat of a buffer and might mitigate some of that. You said energy crisis, that's good. It's something that the short answer is that no one really knows whether it helps or doesn't. But what I can say is there's lots of randomized controlled trials out at the moment. And there are kind of three potential ways that you might want to use that. One is some people think that if you take concussion habitually, it might mitigate any concussion if you have it. So there are lots of people, well, I think about a professional sport context, football, they're almost all taking creatine at a dose of 5 milligrams a day. So there is some thought that maybe that might help mitigate. There are some people that recommend a really high dose of creatine after a concussion. So they'll often recommend 20 grams. So that'd be 4 times as much as others. And then the only randomized controlled trial that I know about that's actually been published was pretty small. And so it looked at 5 milligrams of creatine versus placebo. The short answer is that there's no difference between creatine and placebo. The slightly longer answer is that both groups had a moderate treatment effect size, so they both got better. But then you'd say that's probably what we expect to happen. So that may mean that there's a strong placebo element, but it may be that just doesn't work creatine. So that's my take on creatine. It's probably not going to do any harm other than some low-level GI symptoms. So if you wanted to try it, then I think that's a good one. Then I think we covered off concussion versus vestibular rehabilitation. Are they the same or different? So Kat, I would say that if you have vestibular symptoms, vestibular rehab is a really good idea, but otherwise perhaps not. Anything else to add on one?
Fair? Yeah. Yeah. I mean,
Yeah.
people can have BPPV in the absence of a concussion. So sometimes they'll have positional dizziness. You clear that, they're totally fine. They have no other concussion symptoms. It's possible that was what happened, but I think they do get lumped in together quite a lot, and some of the same principles apply. So don't worry too much about the label. Just treat what you find.
It's an interesting thing, right, isn't it? So like people start off with a concussion and then they develop other things. And so it can be quite validating for patients to understand that their problem is vestibular dysfunction and not concussion, or their neck is sore and not concussion. So that is an interesting one. And then there's a thing around funding and how do you refer patients to our service. So I think there's two things there. One is it's very easy to refer to our service. We try and see patients within the week they're referred. Best thing to do is to send it to concussion@axissportsmedicine.co.nz. Or you can refer into our standard referral pathway as you would anything else, and we'll pick that up. But one thing to note is that we are not able to see people who are already on another concussion service. So my slide before that had a team and then a very spread out team. Unfortunately, if you're seeing a patient under an existing concussion service, we're not allowed to see them for a specialist opinion. So the best option for us, and if you want us to be involved, is to refer them early. And then obviously we can collaborate and share through normal pathways as we go through. And then the first was a good point from Grant at the beginning around concussions getting better in 2 weeks being potentially very optimistic. And I think as Kat then covered off, and I think as I went on to say that, yes, that is the absolute best case scenario. So those patients had early access to fully funded care and follow up through a fully funded pathway with people that were interested and experienced in concussion. So I think as we kind of illustrated, if there's some social issues, there's some mental health issues, that is very unlikely to be the patient's reality. So I find it quite frustrating seeing our own data being presented back to us as a rationale for why we shouldn't see patients in some situations when that data is not relevant to the patient type that we're talking about. So there might be a couple more messages, but otherwise I think we're kind of on the final thing. Okay, Kat, do you have a view on hyperbaric oxygen therapy? Because I do, if you don't.
Or I mean, like the evidence base isn't there. I think it's mechanistically plausible that it might help if you were in a rigid, proper one with supplemental oxygen. But I think it's kind of like creatine is not going to do any harm, but whether it helps is a big query. And I think there's barriers in terms of access. And also if someone is just hyperbaric oxygening and not doing all the other things that we know help, then we're really doing them a disservice. So it would be an on top of instead of an as well as a well-organized targeted intervention plan. Your thoughts, Fulch?
My thoughts are that most hyperbaric oxygen chambers are not hyperbaric oxygen chambers, so they don't get to a sufficient pressure.
The zip ones, the soft ones, yeah, don't. Yeah.
Well, yeah, there's a range of them. And then we recently reviewed this topic with the guys at the Navy who run the hyperbaric oxygen chamber in Devonport, and they were very clear that there was no useful evidence that had any impact on concussion recovery. So I would say the same as you. If it makes you feel better, it will. As we said with creatine, there's a very strong placebo element. So I mean, fill your boots, but it's probably a waste of your time and money. So here's a good one for you from Marinus. How do you structure your treatment if you have a patient with 3 phenotypes? So they might have some cervical, some vestibular, and some sensory motor impairment. Do you clear one at a time, or do you touch on all 3?
Yeah, that'll be Marinus from Sydney. Hi, mate. Yeah, tricky. Though that's typical patient, isn't it? They're never a nice, tidy fit. I think the vestibular system is a mediator. So, you know, if you're sitting in the car and the car next to you starts rolling and you grab the handbrake, it's your vestibular system that goes, no, it's not. Your visual system can be tricked quite easily. So I would try and look at that one, but ideally you would try and bring them together. It's tricky though in terms of what they'll tolerate. So it would depend on the patient's symptom burden. I would generally try and sort of follow one path, but with a little bit of consideration of the other ones. And there, yeah, it's tricky. It would also depend on how long they've been since injury. So if someone was very acute and they had all of that going on, then it'll be a different situation from if someone was 6 months down the track and then you're trying to figure out what's a primary impairment and what's a compensation. We could maybe take that one offline.
Yeah, and kind of from my perspective, from a kind of medical perspective, I often see patients with symptom burden of 100 out of 160, something like that. And I'm very clear with the patients that I'm not going to be able to fix all that problem all at once. And so What is the worst problem? Let's focus on that. What is the one that I perceive to be the easiest? It's often trying to get sleep underway again. So it's about picking off some symptoms, improving, and then having another crack again later. Um, there was a bit more about creatine as a cognitive booster, so at levels beyond 10 milligrams. So I would say, I don't know if I answered that question before, but it's about ice bathing. Same with the hyperbaric oxygen chamber. So if you want it to work, it probably will. The evidence is pretty poor, but it's probably not going to do any harm. And unlike hyperbaric oxygen, it's very cheap. So there is a cost associated with it, but 2 scoops of creatine is exponentially cheaper than a trip to the hyperbaric oxygen chamber. Katie's asked about concussion read codes. So we do not need a concussion read code to be referred. That's something that as part of our standard process, we'll add a concussion diagnosis if we think that there is, if there is one, because I think it's important to have accurate statistics. Can patients who live outside of Christchurch and Auckland be referred to us, and can we treat and assess them remotely? I would say no. We do have patients that are from, say, Hamilton, and they elect to use our service, and they commit to coming up, and we usually see them with a mixture of in-person and remote sessions. I would say Kat and some of the crew do telehealth consultations here and there, but I don't think it would be sensible to for us to run a service for people outside. So
if it's a physiotherapy specific query, then I can see them under the specialist contract. So ideally, if you're their physio with you in the room, and then we could do a telehealth. But and just to note, we do have a clinic in Queenstown and Dunedin as well, so the south is covered in respect to that. It's not just Christchurch.
Here's a good one. Catherine, any advice for a young physiotherapist who wants to start concussion management and be like you?
I just actually replied to that in the chat.
Yeah.
It was quite in short. I said seek out a collaborative workplace with supportive seniors. I think you need to have some support when you're just getting into this, and so that's really key because you want to have some wins. It's can be quite heavy working with these patients, so having ways outside of your work that help kind of lift you up is really, really helpful as well. But I think just get started really is really the only way to do it. I think when Fulch called me in 2016 or whenever it was and was like, oh hey, I'm Mark Fulcher, I've heard you're a bit of a good sort, you want to come work in our concussion clinic? He's like, have you treated much concussion? And I was like, yeah, heaps. And I was just doing vestibular at that stage, but we figured it out.
Yeah, I was about the same. Fake it till you make it.
Yeah.
And then kind of a couple of the vaguely related. What percentage of your concussion referrals are whiplash? And then just next to that, so I'm thinking a lot of symptoms I see are from cranial nerve dysfunctions, a la peripheral neuropathy from the upper cervical spine. So do you want to jump on that one?
I love the phrase whiplash. I think it's so kind of low CBIC as a classifier. It doesn't really mean anything. It's just a mechanism. But yes, there is a huge amount. You'll know the sort of forces that it takes to create a whiplash in the neck are a lot lower than it actually takes to create a concussion. So you can't have a concussion and not have had some type of a whiplash really. And that I see a lot of sort of weird and wonderful cranial nerve things there. As terms of percentages, Jenny, I couldn't give you a number. We see there's certain mechanisms, Fulch will speak to this, that if they come in your door, for some reason people who've got a bang right on the top of the head, they never go particularly well. But other than that, I couldn't say how many have associated whiplash with it, but it would be a lot. Yeah.
And to Grant's comment, it would be undoubtedly that heaps of the symptoms are coming from the upper cervical spine. So any chances of an axis going to Tauranga or around the bay? Our growth strategy is based purely around where people want to go and live. So if you can find a physician that wants to go live in Tauranga and work with us, then pretty good chance. Otherwise, not such a good chance. And one from Anna about what supplementation do we use? And so I'm wondering if that is about creatine. The product that we use the most is Musashi, just because it's batch tested and it's easy to get. But if they're not an athlete, it probably doesn't matter too much. How often are you doing cranial nerve examinations during your physio assessment and concussion?
I think there's sort of two parts to that, Ash. There's a quick screen and then there's a more deep dive. So quick screen in terms of checking the general function of the bulk of the cranial nerves will happen either in their first medical consult or in their first physio consult. There's a really great paper. Nathan Hutting was the lead author on it. It's got a lovely infographic about cranial nerve examination. I know at least one of our physios has that printed out and laminated and up behind his computer. So it's just a little reminder about how you can rattle through it really quickly.
And then this is Jeff, there's another good one from Jeff. So as a musculoskeletal physiotherapist, how much should we know in our screening testing for our patients who walk in and we don't have an existing relationship with them? And so the example is a little old dear, so I'm thinking an older woman who fell and hit her head. Should we just go based on symptoms? So I'll start with that. I think some of these older patients can be quite challenging because there are a huge number of comorbidities that might also coexist there. So there are a whole lot of good decision tools about when cross-sectional imaging is needed. So a lot of these patients, we shouldn't just automatically assume that this is concussion. So if there is a genuine history of trauma, might this be subdural or something more structural? And then I guess the other thing to think about is how bad was the trauma and could this be dementia or a different reason for having cognitive impairment? So we don't have that relationship. It's a lot harder to make an assessment. And I would have a much lower threshold to refer these patients initially to the GP, but then potentially to ED or onwards. I don't know if you've got anything to add about that, Kat.
Yeah, I mean, I think it's whether the clinical picture fits, and we have had lots of cases referred that aren't concussion, and it's query fall, but actually the person's ended up being in early stages of dementia or things like that. So I think it's limited to what you can assess in terms of what you could be doing in a normal clinic. Standard muscular practice is quite challenging.
Yeah, but I mean, I don't think it'd be a wrong thing to do if they had relatively limited symptoms, fairly benign story, fairly
Totally.
normal examination to treat it as you would anyone else and see how they go. But I think you have to then keep thinking, is this not getting better because are these symptoms actually quite bad? Maybe we need to do something different with them. I don't think there's a real climate to do something. And then the last one would kind of wrap up because we are a little bit over time. It's just around other supplements. So I don't really talk to patients about supplements that much, with the exception of creatine. Melatonin is something that we use a lot. So melatonin is a really good way to facilitate sleep. And until I think actually still it's a prescription medication in New Zealand. It's over the counter in other parts of the world and soon to become over the counter like pseudoephedrine. One of these election promises. We must have melatonin now. And so I imagine that might be something that you might want to consider. So there's some evidence to say that melatonin can help with concussion recovery. So not compelling. But the other thing is that it certainly can help people initiate sleep. So for patients after a concussion having difficulty initiating sleep, that is definitely something to think about. The dose is probably not that important. Most of them are 2 milligrams, 3 milligrams, sometimes up to 5 milligrams. So I think that's a wrap. Catherine, excellent job. Natalie, excellent job yourself as well. Really looking forward to hearing what you get up to for dinner. And thanks very much to those of you out there for spending some time with us. We appreciate your time is precious, and thank you for giving us an hour. We will make sure that we post the recording out in the email and send you some links to some of the other things that we're up to. Otherwise, keep an eye out just before you drop off for the spin. It's going to be amazing. There's going to be some amazing content in there with some details about what we're up to and what's happening over the next few months. So thank you very much, Naomi.
Thanks,
Good
guys.
night.